To a high point of the meeting when we will next hear from our keynote speaker, Dr. Robert Bourge. He is, in collaboration with his colleagues in cardiovascular and thoracic surgery, started the first ventricular assist device program in the southeastern United States. Shortly thereafter, Dr. Bourge became the founding medical director and president of the Cardiac Transplant Research Database, which holds extensive data on over 12,000 heart transplant recipients and the compiled experience of 45 heart transplant programs in North America. Activities of this kind of transplantation have really had a very important role in the whole history of the transplant program. And I've just read Tom Starzl's autobiography, in the sense in which he pointed out the great value of having this kind of data available. In 2004, Dr. Bourge was awarded the M.G. Waters Chair in Cardiovascular Disease at the University of Alabama in Birmingham. Since 1996, he has been director of the Division of Cardiovascular Disease and co-director of the university's Heart and Vascular Research Center. We're looking forward to hearing from you.
Thank you. It's nice to be near my roots as a Cajun from South Louisiana. My ancestors came from Acadiana, and indeed, to me, everything above Interstate 10 in South Louisiana is Yankee. So I'm very far north here, believe me. I'm honored to be here. As I've told Martine for many years, I'm a country cardiologist taking care of patients, and to be amongst this learning group is truly an honor for me. Today, I'm going to discuss implanted hemodynamic monitoring, and I always like to give my conflicts. I'm funded, most of my work is funded by industry, because that's where the source has been, although I am a consultant to the FDA and to CMS in the United States on the utility of these various devices. Let's see. Just to remind me, how many in here, please raise your hand, have a medical background or physicians? Okay. Well, let me start with an explanation then. Heart failure, which is one of the things that I treat specifically in Alabama, is a condition when an abnormality of cardiac function causes the heart to fail to pump at a rate required by the metabolizing tissues, or very importantly, and more importantly, the heart can only do so with an elevated filling pressure. So we can have a normal pump in terms of the squeeze, but because the heart's too stiff, and diastole, the pressures have to be very high for it to fill. Our cardiac output drops. And at least 50% now of our patients with heart failure have so-called diastolic dysfunction or heart failure with normal systolic function. And there is no approved drug for that. There is no approved therapy for that, still to this day. We have some on the horizon, we hope, but there's still no therapy. So today I'm going to talk to you how we've used telemedicine to hit this U.S. population. This is a U.S. population greater than 65 years of age. And you can see in the year 2000, there were 34.9 million. It's estimated in 2020 there'll be 53.6 million people. And of the population greater than 65 years of age, almost 20% develop heart failure. We like to tell our colleagues, if you keep your patients alive long enough with cancer, with infectious disease, with whatever, they'll end up in my clinic. And indeed, the older you get, the higher the chance of developing heart failure before you die. And it's going to be a tremendous burden because of the costs associated with it. This is a classic picture from Netter's illustrations on heart disease, where he describes a patient illustrates a patient with left-sided heart failure. Is having trouble breathing. You can see on the chest x-ray that indeed there is pulmonary edema, the heart's enlarged, the pulmonary veins are engorged, the patient's neck veins are very high, indicating high filling pressures. If we wait to this, it's often too late. The idea that I've been promoting, and many people have for many years, is that it's the congestion. And blocking the congestion long term, along with blocking the neurohormonal pathways, which make heart failure worse, is what's going to improve our patients down the line. It's interesting, over the last 30 years that I've been doing this, we've gone from treating symptoms and just hemodynamics to the realization if you just do that, you don't prolong life, to then treating the neurohormonal pathways to prolong life, to now back to the importance of both. We must do both in terms of extending life and improving patients' outcome. The symptoms of heart failure, unfortunately, are both insensitive and nonspecific. In fact, in a young person who comes in with dyspnea and cough, 90% of them are treated with an antibiotic first before anybody listens to their heart. And sometimes that goes on for weeks to months before heart failure is discovered. Same thing for pulmonary hypertension, unfortunately. Great weight gain, in my case, hopefully is not due to heart failure. It's because of the wonderful meals I've eaten since I've been here. Feeling of tiredness, you're going to get in about 30 minutes into my lecture. And I'm hoping you don't have heart failure, but I will show you something on the way that I think might wake you up. And there's abnormal lung sounds, but they're not specific whatsoever. Again, they're not specific. The physical exam is not sensitive or specific. It's prone to errors. The chest x-ray findings have limited accuracy for heart failure. And again, 1/3 to now 1/2 of patients with heart failure have normal systolic function. The heart squeeze is normal. So I get calls all the time. Well, I have a patient, he's really short of breath, but man, his echo looks great. He's got an ejection fraction of 65%, normal being above 45 or 50%. Well, he has heart failure, and that is because he has diastolic dysfunction. We know that the routine estimate of left-sided filling pressures in the medical management of heart failure is difficult and fraught with error, but it's mandatory. It has to be done. And even if you're seeing a patient routinely in a heart failure clinic, you see them less than 5% of days. So 95% of the days of the year, no one's seeing them. No one's assessing their volume. The weight and edema, as I said, are unreliable over time. For example, this patient has got a lymphatic problem, so the left leg is swollen while the right leg is not swollen. We know that when you see edema, you have patients usually over 2 liters of fluid retention. 2 liters. That's over 5 pounds of fluid retention before you develop edema. In fact, it's amazing what patients can hide in terms of fluid. My record for diuresis in one particular patient who was quite large was 137 pounds and 1 hospitalization. Remarkable. Remarkable. If we look at what happens with acute exacerbations of heart failure and subsequent hospitalizations, there's a clear correlation. A friend of mine, Dr. Jane, drew this presumed time with an acute event requiring hospitalization and then the clinical status getting worse and worse. And in fact, if you superimpose the number of hospitalizations on the patient that's had and their mortality, it looks exactly the same. The more acute decompensations, the more we have to treat them with poisons, and that's what we do. Diuretics are poisons. That's how they work. They poison the kidney, and that's what I tell our patients. If we can prevent high-dose diuretics, we can prevent the use or preclude the use of intravenous inotropic agents, you will live longer. How do we do that? Well, I'll show you one suggestion, I think, of how we should do that. But if there's one take-home thought from this lecture, it's congestion, as evidenced by increased intracardiac end-diastolic pressures, means worse symptoms and certainly worse survival. And there's more and more evidence. Well, up until now, what we've done is we've trucked along seeing our patients monthly. Some of my patients I have to see biweekly, but usually we see them intermittently. And we wait until symptoms get worse until they have an event. So if we graph days and we graph pressures in the heart, symptoms usually start 1, 2, 3, sometimes 7 days before an admission. Now, it depends on what you're doing and where you are. For example, in South Louisiana, where I'm come from, you'll get symptoms because you go out and you have a big tub of boiled shrimp, very salty. Then you have the beer with it. And if you have the beer with it because the salt makes you thirsty, you end up in the emergency room between midnight and 2 a.m. In Baltimore, it's crabs and beer. In Texas, it's ribs and beer. In Birmingham, it's almost anything in beer, where I'm from. And you see some of the weights that I'll tell you in a second about where some of these patients come from. Now, what we're doing here when we wait till the event is we're becoming reactive to the increasing pressures. And we're forced to use these poisons to treat our patients. And I would suggest to you that these pressure changes occur long before that event. And indeed, I'll show you some data to that effect. So if we could become proactive and know these pressure changes within the heart, we may be able to prevent that heart failure event. So we become proactive rather than reactive when we do medical intervention here versus during the acute event. We save hospitalizations, and hopefully we improve morbidity and mortality. Now, do we need to do this with physical exam? We could. If I could see a patient every day in clinic, sometimes twice a day, measure their pressures with the exam, I'm quite frankly right about 80% of the time, but not 100%. And I've done this for 30 years. Still, we have patients we can't tell the pressures with physical examination. I've published extensively on that. We can measure serum BNP. We know that serum BNP, brain B-type natriuretic peptide, goes up with filling pressures. This is the wedge pressure, or left ventricular end diastolic pressure, and it charts along with the patient diuresing, and the BNP goes down as the wedge pressure goes down. The problem is right now there's no home BNP monitor. Hopefully there will be one, because it could be done that way, similar to an INR and other things, and I'm hoping there will be one. But in addition, we know that it's really useful only if done serially in the same patient. As an index of a group of patients, it's not that good. For example, I've modified this extensively. If the BNP is less than 100, the patient's okay, volume-wise. If it's greater than 400, they have severe heart failure, but they may need to be greater than 500. About 30% of my population has to have a BNP between 500 and 600, or they go into renal failure. So you can't just do it in isolation. And anywhere in between, it could be a lot of things causing it. In patients, for example, with primary pulmonary hypertension, who have right-sided heart failure, which is short-lived, a BNP of 150 has a horrible prognosis. If it's long-standing, it may need to be 400, and they have a good prognosis. It all has to do with the thickness of the right ventricle in that particular disease. Well, back in 1992, and I've been working on this quite a while, I chaired a scientific advisory board for Medtronic to look at the possibility of using some technology they had developed to be used in pacemakers. The technology included a pressure measure and an SVO2 measure, a measure of the oxygen capacity in the blood. They were doing that, and they had developed that to try to adjust pacemaker rates to activity. So if the patient needed more, pacemaker would pace faster, et cetera. And that was a relatively slow process, but by the end of the 1990s, we were doing clinical studies, and the first phase 1 and 2 studies were done in the United States. We had data after placing this device into over 100 patients. The device is implantable, has a 4 to 5 year battery life. It has a significant internal memory, and it's programmable. We can program the resolution. So what it does is it detects the pressures in the right ventricle, measures them over a period of time, anywhere from continuous to up to 30 minutes, and then averages it. And we get lots of parameters: pulmonary artery systolic pressure, which is the same as right ventricular pressure, pulmonary artery diastolic pressure, which is equivalent to left-sided filling pressure. So it tells us the filling pressures on the left side, so the volume on the left side, and the volume on the right side of the heart, because they can be different. It gives me an index of contractility, of how well the heart's squeezing, because it gives me right ventricular DPDT, or change in pressure over time. It gives me electrograms, electrocardiograms, if you will, so I can tell arrhythmias. It gives me heart rate, it gives me temperature, and it gives me an activity. And it records it continuously. And we usually set it up for what we call 1 month resolution, which is really 5 weeks, just in case the patient doesn't upload. And it's programmable, and it has a number of components which allows me to look at it. This is the device. It's like the size of a small pacemaker. Actually, this is the A device. A B device is actually smaller than this, the newest one. It's placed in the subclavian vein, through the right atrium into the right ventricle, and placed up against the septum here, so that it is detecting pressure away from the wall of the heart, and it essentially allows me to measure pulmonary pressure indirectly because the right ventricular systolic is the same as the pulmonary pressure. It again measures RV diastolic pressure at the start of the QRS depression, which is the same as RV end diastolic pressure. It measures RV systolic pressure at the peak of the waveform here, number 2, which is the same as pulmonary systolic. And interesting enough, we were trying to figure out how to look at pulmonary RV end diastolic pressure, and it was discovered 30 years ago. We went back in the literature and found lots of studies proving that if you measure the RV pressure at maximum dPdT on the upslope, it's equivalent to the pulmonary artery end diastolic pressure, with quite accurate, actually. I'll skip that. We proved its utility in a number of early patients. This is 32 of the first 110 patients. And if you measure it compared in a whole series of experiments with the patient lying, standing, coughing, Valsalva on an exercise test, remarkable correlation of systolic, diastolic, and EPAD, RV systolic, RV diastolic, and EPAD to a Swan-Ganz catheter. In fact, it's more accurate than a Swan-Ganz catheter because a Swan-Ganz is fluid-filled. This is a micromanometer, essentially tipped catheter. In subsequent studies that I did with a micromanometer, it's more accurate than a Swan-Ganz catheter. It also doesn't drift. This is over 12 months, remains accurate at least out to a year. So we showed that it was accurate, and we showed over the course of 4 years that we could get the data. We even developed a website so we can look at the data on a website. So we developed a program where the device is placed, the patient at intermittent intervals interrogates the device with a small computer. This transmits the information to a central server, and then I'm able to look at it. In fact, just before this lecture, I was on the back of the room looking at my patient's data and emailing my nurses as to what to do for my specific patients. So it's patient-specific prescriptions for controlling congestion. It's interesting that when we started this program and started putting the monitors in 1996, we didn't know what to do with the data. I've looked at personally over 5.5 million pages of data. 5.5 million, because I have access as the principal investigator to everyone's data from all institutions. But it's remarkable how it has changed how we think of heart failure. It's totally revolutionized it, and you'll see more and more data being published on this. This is the website where we actually sign on. We get pressure readouts such as this with the mean and the 96th percentile and the 4th percentile at the up and the bottom and the top, as you see. We get specific list of patients. If a patient's overdue, we call them to transmit. And I came up with, in 1997, actually, this list of potential clinical applications. And I'd like to share with you how far along these potential applications are we as of today. I thought back then it would improve our understanding of the hemodynamic alterations that occur with heart failure and, very importantly, the response to therapy. And I'll show you a few examples. For example, in the COMPASS HF study, which I'm going to show you, the large randomized trial, if you look at the mean of the daily pressures versus the variability. For years I've said in patients who have marked variability in pressures throughout the year, it was my impression that they did worse. They had more events. Only now do we know, yes, both in the chronicle group where we could see the pressures and in the control where the pressures were actually hidden from us for 6 months. In both sets of patients, the mean had more events than no events if the mean was higher, and the variability also tracked significantly with events. So we know it's not just the pressure, it's the variability within the same day on a patient. We also, I hope that it would allow more precise titration of tailoring their medicines in patients with heart failure and pulmonary vascular disease. This is an example. This patient referred to me with severe congestive heart failure on intravenous inotropes from another hospital on a balloon pump for heart transplantation, transferred from Atlanta to Birmingham. And indeed, if you just looked at his information on a day-to-day basis, his right ventricular diastolic pressure looks flat, as does the snapshot of his pulmonary pressure. But when we really go down into the data, we see huge variabilities in his pressures. And if you look at this, we see the diurnal variation of pressures to the extreme. And we were catheterizing him, as typical, first thing in the morning with him MPO, without food. So at 8 o'clock, his pressures aren't that bad, 32 over 8. Look what happens by 1 o'clock. His RV pressure, PA systolic pressure, 70, 75. Normal being about less than 30 to 35. Huge difference. That's why he's so sick. Based on this, I changed totally his medical regimen. I stretched out his diuretics to smaller doses. I started him on Isodil, long-acting, to keep his pressures down. And I told him, do not drink a ton of water in the morning after you take your diuretic, which is what he was doing. Indeed, just in that, within 3 months, these are his pressures, almost flat. He went from class 4 inotropes to class 1, no symptoms whatsoever, off the inotropes, and he was removed from the transplant list. He went 4 years before he needed a transplant. He had ischemic heart disease and needed it eventually. It went a total of 4 years just by specifically applying what we learned from these patients to his individual prescription. Could we also provide an early warning of hemodynamic deterioration? Well, that's what we want to do. We want to pick it up early on. For example, here's a 68-year-old gentleman. I have many examples with him because he was not the most compliant guy in the world. He loved the pizza and beer. He had diabetes, ischemic heart disease. His ejection fraction was almost normal, but he had severe diastolic dysfunction. And he called me because he was feeling a little short of breath. Now, you could say, Bob, why wouldn't you just tell him to take an extra metolazone and an extra Lasix, which is typically what I would do. But remember, we don't just get pressure, we get heart rate, and we get DPDT, which unfortunately I don't have in him. But look what happened to his heart rate as he called me. It had plummeted. RV systolic pressure was up a little bit. RV diastolic pressure was up. Does he need diuretics? Estimated pulmonary artery pressure was up, which is typical for him when he decompensates. Now, what I've found, and I've reported, is that this almost always means a severe metabolic problem, usually severe hyperkalemia. So despite his protestations, I insisted he come to the emergency room, and he was found to have a potassium of 7.7, enough to kill him. We corrected that, diuresed him, and look what his heart rate does. Comes right back up. His pressures fall like a rock, and he's back to where he is. So in 36 hours, he was out of the hospital rather than dead. So, and I actually have 20 cases like this where we picked up a drop in RV-TBDT associated with a drop in heart rate correlating with severe metabolic problems. This is another little girl. I won't go into great detail, but she's a lady who we eventually transplanted, but she was 21 years old and was very non-compliant. If you notice the date, she calls me on this green line. This is right before Christmas, December 16th, 4.5 years ago. And her pressures have been gradually going up. I told her to take an extra diuretic and report to clinic the next morning. She didn't come. She didn't come because she didn't want to be in the hospital over Christmas. And indeed, she was extremely ill with an ejection fraction of 10%, being evaluated for heart transplantation. But I was concerned about her compliance, so I was not going to transplant her. Because remember, if we transplant somebody who's non-compliant and they die, we kill 2 people. We kill them, and we kill whoever could have had their heart. So we don't look at it lightly. Well, indeed, I'm following her pressure. She's calling in. I'm calling her every day, telling her to come to clinic, come to clinic, come to clinic. Well, on this day, right here, I see her heart rate to start to go down, and very important, I see her right ventricular pulse pressure and her RV-DPDT going down. Now, this is one of the problems that I see in pulmonary hypertension patients. A person who's not really measuring the pressures of the outputs and just looking at pulmonary artery pressure, they think, well, a drop in RV systolic or PA pressure, that's good. They're doing better. Well, in this case, just like with some of our patients with pulmonary hypertension, that pressure is dropping because the right ventricle is failing. The drop in RV pulse pressure is a kiss of death. Well, I called her and screamed, talked to her parents, her boyfriend, everybody. She came to the emergency department. Indeed, she had a potassium of 8, and ALT, liver function enzymes, were 20,000. She was in cardiogenic shock. In fact, she ended up, after 2 weeks of hospitalization, on a left ventricular assist device. Now, she had to prove to me for 2 years on that left ventricular assist device that she was totally compliant, which she did. I even got her a job in the organ bank at UAB procuring tissue. After 2 years of being the perfect patient, we transplanted her. She's now 4.5 years out doing great, still working in the tissue procurement lab. So she grew up, and she survived. Can we aid in the diagnosis of asymptomatic events in the outpatient setting? Because not everything is heart failure. Well, this is one of my first patients. In fact, it was the first patient I placed in 1996, I think. And this is before we had the ability to look at pressures online. They had to come back to clinic. I had to download them on a PC with a wand, and then I had to do an Excel spreadsheet to look at the information. This is early on in the development of this. Indeed, I placed this device on October 13th in this gentleman, and he goes home. He comes back to clinic where this red line is, and I see that indeed, if you look activity and heart rate, so activity is down here, the green dots, some moving, and then heart rate went up from 70 up to around 110. Now that's a bad sign in heart failure. Typically you get sympathetic outflow with worsening heart failure, but his only complaint was he had a cough, which started 3 days before the clinic visit. He had not called us. He had a hacking cough with minimal production. As we look at the other information, we see a gradual rise in his RV systolic pressure and a little bit rise in his RV diastolic pressure. It's high though, it's 60. Now, is this heart failure? Do I just give him some more diuretics? Well, that's why I tell my fellows and my residents, always look at everything. Don't assume. And indeed, his EPAD had gone up. Heart failure, huh? Give him some more diuretic. Well, look at his temperature. The device measures core body temperature. It had gone from 37 degrees to 39.5 degrees. And indeed, clear lungs, nothing on exam, scant cough. If we look at this in retrospect, nothing would have pointed us to the fact that he had pneumonia other than this. His oral temperature and his ear temperature were totally normal, but the core temperature was up, so I sent him for an x-ray, and he had a right lower lobe pneumonia. Not detectable on physical exam. I gave him azithromycin as the only treatment, no diuretic. Can you go back, or can I go back? Look at his temperature. Boom. Look at his pressures. Boom. Came right back down. I've actually done this multiple times remotely. I'll get a call from the emergency department where I have a patient in there with a cough, and the patient and the ED doc will say this. I said, have them download their data, because I have them carry the little computer with them. They upload the data, and I said, I'll always say, check a chest x-ray, because core body temperature is up, even though the oral temperature is not. Now, lastly, the two I put together, could this type of information provide a method by which to develop, refine, and optimize the use of chronic hemodynamic data for long-term patient management? And could we affect the intermediate and long-term morbidity and possibly down the line mortality? Hard endpoints to prove, but I believe it has the potential to do that. But before I go on, remember I said you have to look at everything and don't assume. We'll start with a little video. Excuse me, good morning. This is in Italian. Do you know what time it is? Gentleman reaches over to the donkey and raises his testicles. Says it's 10 past 10. Are you sure? Just like I said. So the guy goes on. Thanks a lot. Good, you have the audio. Good. So that afternoon he comes back, and who's still there? Great day today, huh? Yeah. Tell me, what time is it? What, again? It's 7:15. Damn. It's exactly. How the hell do you know it's 7:15? Just by touching the donkey's balls. That's easy. It's on the village clock. So things are not always what they seem. Always look at everything. That's from an Italian commercial, by the way. Now, that being said, let me show you the first randomized trial that looked at this type of application in the patient population. It's a Compass HF study, recently published in the Journal of American College of Cardiology. And our hypothesis is that if we did a management strategy based on continuously monitored intracardiac pressures, already on optical medical therapy, we could improve morbidity. I wanted to do a 650 patient study. I fought with Medtronic for 3 years, and they agreed to do a 200-and-something patient study. We compromised. We did what they would pay for. And indeed, you'll see what happened. I tell my patients all the time, I'm always, as I've told many patients, I'm always glad to compromise as long as you do everything I say. The endpoints were primary efficacy, heart failure hospitalizations, emergency department visits, or as we have our own heart failure emergency room and clinic. We don't like our patients to go to the ED. They come to our own clinic and get IV therapy, or to my own emergency room on weekends. And we looked at safety endpoints, because you're operating on a patient to put this device in. Patient selection, class 3 and 4 heart failure, so patients with symptoms at rest or with minimal exertion who were treated with standard medical therapy for 3 months. In fact, this was standard medical therapy in a heart failure program. The patient had to have at least one heart failure-related hospitalization necessitating therapy in the 6 months prior to baseline. Now, they were blinded as to what assignment they were for the 6-month follow-up visit. It was a randomized single-blind study. Every patient, whether we could see their information or not, transmitted at least once weekly via the home-based monitor. We used standardized communication strips. We did scheduled surveillance calls. And it's interesting, as we track this, that patients, this is the most intense heart failure program I've ever worked in. The average contact with a patient was every 5 days for 6 months. So you would expect that to lower the event rate. Well, we calculated an event rate conservatively at 1.2, and you'll see we didn't make it. The event rate was much lower, partly because of this. I'll skip statistics and just show you that we randomized 274 patients. We had 3 unsuccessful implants to control group where we couldn't see it, chronicle group. And these were the mandated clinic visits, but most patients were seen monthly. And at 6 months, all patients went into an open label phase where we're still able to look at their pressures and manage them. Remember I said we worked on this for 4 years. Well, during that 4 years and over 100 patients, we developed patient care guidelines. And at every time we get the information, both patient information, weights, everything, and the hemodynamics, whether we can get them or not, depending on the group, we classify the patient in 3 subsets. Hypervolemic, that is the pressures are high, either by physical exam weight or physical exam weight and the information. Optivolemic, which is the lowest pressure that they'll tolerate without developing signs of symptoms of low cardiac output. Typically, that's worsening fatigue or worsening renal function. If you over-diurese a heart failure patient. We were worried. Could we make things worse by knowing these patients? Could we put a whole bunch of people in renal failure by over-treating? We didn't know. Or hypovolemic, clearly dry, where a patient needs more fluid. All of these resulted in specific recommendations as to therapy, which we tracked. The 2 groups were very similar, both in age and almost all variables. All safety objectives were exceeded. The device worked. We had complication-free survival at 6 months of 91.5%. We had a few lead failures, which were subsequently replaced. In all but 1 patient, the device was working. That patient refused to have the lead replaced. We had no sensor failures whatsoever. If you look at, again, how often the patients were called, the phone calls were 24 over 6 months. In addition, the patient was seen an average of 5 times in clinic. So that's where I get that rate of about every 5 days. Well, this is our primary objective, and the percent reduction in events was only 21%. Well, and it did not reach statistical significance using the very conservative negative binomial method. By Poisson model, it was 0.09. And one of the reasons, as you'll see, I'll talk about in a second, is the control rate was lower than any other study I've been involved in. It was 0.85 because we were watching them like hawks. And the event rate in the chronicle group was 0.67. You can see the cumulative events, they're separating, but did not reach significance. Now, I wouldn't call this a negative study, although the editorial that accompanied the patient called it negative. It's really neutral. Negative would mean we made things worse. We didn't make things worse. If we look at time to event analysis, significant reduction in first hospitalization rates, which is classic for a heart failure study. Can we prevent the first one? We divided into subsets as we said we would do. Class 3 patients were 85%, Class 4, 15%, so very few Class 4s. If you looked at the Class 3s, it actually was positive. Just the Class 3s, we saw a reduction hospitalizations and 36%. But because we didn't stratify, FDA would not accept this as a reason to approve the device. And interesting, if you look at the heart failure hospitalizations through 12 months in all patients, and the chronicle group versus control, 50.56, these are patients who had data in both sets, this 6 months and then this 6 months. We see 0.56, 0.9 in the control group. And look what happens when the control group gets to the post-randomization. Same rates, identical rates. We're able to drop the rates in those same amount of patients. In fact, if you remember what I showed you about being proactive, this is what happens prior to hospitalization in the chronic group versus control. 14 to 21 days before the index of them coming in the hospital, we're seeing a significant rise in pressure compared to after diuresis in their baseline. Indeed, if you looked at body weight, and this is why I say weight, look at the average weights here. A lot of patients in the southeast. The average weight in the chronicle group was 240 pounds. Got some big people. But again, we were putting people in this because we had trouble detecting their pressures on physical exam, and that typically is an overweight person. Now, does this mean that body weights don't work? No. It means that if you're using body weights to adjust your therapy, we can, on top of that, we hope, by measuring pressures, adjust therapy further. And if you look at these same patients, you can say 7 weeks before the index admission, there was a significant change in their hemodynamics, as long as that. This is what happens to the pressures. This is change from baseline. In the control group, you see there's no change because we couldn't see the pressures. So by physical exam, we weren't adjusting. But look what happened in the chronicle group. And then after 6 months, the control group acts just like the chronicle group in the first 6 months, and the chronicle group continues to improve, very highly significant change from baseline out to 12 months. So in summary from that study, I think we believe the chronicle IHM system is safe and reliable. We saw a 21% reduction in heart failure events beyond the currently available therapy. There were 3 times as many adjustments of medications in the chronicle group, including diuretics, and simply calling the patient and saying, don't eat so much salt. That was one of our interventions. We saw a 36% reduction in relative risk of heart failure-related hospitalization, and we need additional trials to get it approved because, again, it was a neutral trial, not a negative style. We also have used this in pulmonary hypertension. We did a sub-study of a pilot implanted hemodynamic monitor in pulmonary hypertension, and what we showed was we could actually determine cardiac output. And now this is one of the outputs from our system. Once we develop a constant for the individual patient, we're able to calculate cardiac output, and once you apply that, this is, for example, during a vasodilator study in a patient with pulmonary hypertension, you can't even see the white and yellow. It's almost too good to be true, quite frankly, but they're almost superimposed in these individual patients at a wide variety of cardiac outputs because we were giving them vasodilators. And this is the cardiac index measured versus estimated with an R value of 0.95, and here's your Bland-Altman chart showing very good correlation. So this device, along with another, we're able now to, in addition to tell pressure, we're able to calculate and transmit cardiac index. There are other devices which I'll mention. One is a SaverCore heart pod. It's placed across the intra-atrial septum through a transeptal approach. This is the shortest lived scientific advisory board I've ever been on. They asked me to be on it, and as I told them, I said, I always tell the truth. You want me to tell the truth? Yes, yes, we do. Well, in the room with some venture capitalists, and I told them that it would never work because you're going to kill somebody putting it in. There's only 4 people in Alabama that can do a transeptal approach successfully and repeatedly, and they're all in my university. How would you ever market this? It's too hard to put in. You got to punch a hole in the septum and thread a wire through. You're either going to have a stroke and somebody's going to die, or you're going to have an air embolus and a stroke and somebody's going to die. Well, up until 3 weeks ago, they were proving me wrong. The first 40 patients, there were no complications other than the lead went out in 12% of them. That's a problem. The 41st patient died 3 weeks ago with it being placed because they had an air embolus and a stroke. So we'll see what happens with this device. It's just too hard to put in. This is the newest device I'm working with now, the CardioMEMS wireless heart failure sensor. It's not nanotechnology, but I think you can see it's MEMS technology. It's placed in the pulmonary artery. If you look at a proof of concept, their pressures versus the device, it's more accurate than a Swan-Ganz catheter. This is it in the pulmonary artery. It's placed there, if you will, permanently. Here's a brief video showing how we do it. Any internist who can do a Swan-Ganz catheter can place this device. You can either do it from the neck or from the leg. You simply float a Swan-Ganz catheter into the pulmonary artery. Let the balloon down. You put a wire through it, leave the wire there, pull the Swan-Ganz catheter out. Then over that, you introduce the deployment device. This device, you simply twist something and these little wires pop out, nitinol wires, which are the antennas, by the way. It stays right in the middle of the artery because of that. Very easy. And then the patient takes it home. He has a radio transmitter underneath his mattress, and every morning, and in my patients in the afternoon also, they lie down and they push a button, and in 20 seconds it does a reading. It automatically transmits that information to the central data server, and I look at it. In fact, since I've been here, I've been receiving these twice a day on every one of my patients on my PDA. And I can have it programmed, so I'll push one button. That button sends an email back to my study nurse if the patient needs to change anything. And how well do we do with this device? Well, we're doing a study, a randomized study, just like the Compass HF study, except it's going to have the 630 patients I originally wanted, so it is powered to show the difference. That's number one. And number two, we use the things we learned from the Compass HF in tweaking the next study. This is an example. If I can have the next slide. Can you go back one? Sorry. Thought I had it on there. This is another technology which is quite unique from Riemann Technology, now purchased by Boston Scientific. It is, again, MEMS technology, very small. They elected to put it in the main pulmonary artery against my advice, and it does work, but it's much harder to put in and to get it to be anchored. It has a micro lithium battery, greater than 5-year battery life, and it can actually be charged. It runs by ultrasound, not by radio waves. In fact, you can hold the device in your fingers here and hold the receiver here just with your fingers being wet and do a reading. It's remarkably sensitive. You can put the receiver on your foot and read it from within your lungs. It uses low ultrasound. This is a device, I won't go into it, I'll skip it since we're late. So in closing, I think our potential applications have largely been proven, not to the good of the FDA, slaves to p-values as they are, but hopefully our next study will be able to show that we can use this telemetry information to improve our patients' lives, and we can get past some of these older therapies for heart failure. Thank you.